Hello everyone, welcome to today's webinar, Image-Guided Pediatric Patients Using Indocyanine Green ICG Fluorescence in Minimally Invasive Surgery. Before we get started, I'd like to go over a few housekeeping items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce Professor Ciro Esposito. Professor Esposito is the Surgeon-in-Chief and Director of the Department of Pediatric Surgery at the University of Naples Federico in Italy. He is an honorary member of French Academy of Surgery in Paris. His research activities include applications of augmented reality, artificial intelligence, and telementoring in pediatric MIS, robotic surgery, endourology, and new techniques in minimally invasive surgery. Ciro Esposito is reviewer of a variety of surgical peer-reviewed journals and editor of 10 books of pediatric surgery and pediatric MIS. Past president of European Society of Pediatric Endoscopic Surgery, he is the director of MIS and robotic pediatric courses at University of Naples since 2006. Over to you, Professor Esposito.
Thank you very much for this kind introduction, and I would like to show you the application of ICG enhanced fluorescence technology in pediatric mini invasive surgery. As you know, that in the last few years there were a lot of papers focus on the use of ICG technology, but this paper, the majority of studies are focused on adult population. My talk is focused of application of ICG in pediatric patients. As you know, there are a lot of application of ICG in pediatric patients, and I used this product in the last 3-4 years, and we have the pleasure to publish some papers on this topic. First of all, it is important to underline that in pediatric mini-invasive surgery, to use ICG, you need laparoscopic equipment. First of all, you need a special camera, a special ICG optic, and for sure the vial of ICG. There are two systems. I will show you both of them. The classic system, you have a pedal, and with the pedal you can switch from normal view to ICG view. Using the standard system, when you switch to ICG view, the screen became black, and you see in green or in blue the structures. With the new Rubin assistance, I will show you keep the color, and there is a lot of advantage. I will show you with my videos, which are the indication. We recently published on Frontiers, which are the indication of ICG in laparoscopic and in robotic surgery. This is an open access journal. For this reason, you can download this paper free of charge. Starting for the hepatobiliary surgery, this is probably at the beginning, the first field of application of ICG. And in particular, in pediatric surgery, we adopt this technology for cholecystectomy. As you know, cholecystectomy is a frequent procedure in adults and also in children, but there are at least in some series 20–30% of complication during cholecystectomy. Why? First of all, because as you know, in adult centers were operated about 300 patients per year. For this reason, they have a huge experience. In pediatric centers, we operated 10% of patients compared to the adult. For this reason, in each pediatric surgical centers, we operate to 10 to 30 patients per year. For this reason, we have less experience than in adults. And it's important to underline that sometimes you don't find the classic biliary anatomy, and there are in about 30% of patients the biliary tree anomalies. For this reason, it's important to know the anatomy, and I think the ICG is the best way to realize an intraoperative cholangiography, a real-time intraoperative cholangiography. As you know, it's important to standardize the technique of injection, because if you inject the product intraoperatively, you will see only the liver but not the biliary tree. For this reason, we standardize the technique of injection. First of all, as for when you have to perform a cholecystectomy, you have to use a vial, and you have to dilute the vial with 10 ml of sterile water, and you have to inject 6 milliliter of solution about 15-18 years preoperatively. In this way, the day before, if you open the child in the morning. Is important because the ICG was metabolized from liver and go directly in biliary tree. And in this way, during the procedure, you can see only the biliary tree. I will show you. Which the advantage is that you can see the anatomy. As you can see in this way, switching with the pedal, you can see the gallbladder, you can see the cystic duct and the main biliary tree. In this way, is extremely easy thanks to this ICG technology, avoid complication. You can see switching with the pedal, you can switch to a normal view to ICG view. Then you can also in difficult cases with a lot of adhesions, as you can see in this case, you have a good identification of biliary anatomy. This is a difficult case because you can see there is an angulation of cystic duct with the gallbladder, and there is a lot of adhesions, and for this reason there are you can identify the biliary tree and avoid complication. And this is the same case. You can see switching with the pedal, you can pass to the ICG view to the normal view, and in this way you can identify in a better way the cystic duct, above all the main biliary tree. In this case you can avoid complication, above all if there are a lot of adhesion, because these patients in the majority of cases have several episodes of inflammation before surgery. For this reason you can identify the biliary anatomy, and as I told you, as you can see, is extremely clear the anatomy. As you can see, the gallbladder, cystic duct and main biliary tree, as you can measure the length of the cystic duct before positioning the clips, but you can see is very, very useful. And then there is the new system that is the Image One Rubina, and this is a modular platform that offers more than the traditional ICG. Why? Because Rubina system is only one solution, and thanks to its modular architecture, they can permit to have a vision in 4K, 3D, and a LED technology. And is important because you can add, if you have as in pediatric surgery, the majority of centers have stores equipment, you can add this component to the existing platform. And this is the Rubina video. As you can see, you are performing a cholecystectomy. It is not necessary to switch to the black screen. You can press a button and you can see in green the biliary tree. This is the advantage because you can continue to operate in color. You can see in this video in a normal view, but I can guarantee that if you have a 4K screen, you can see very, very, very well. And as I told you for previous video, you can dissect, you can remove the fat from the cystic duct, and you can easily identify the structure. In this way, you can perform an easy dissection, reducing complication. We adopt now this technology for every case of cholecystectomy. In this way, also training can perform this procedure. And then you can use this is always Arubina videos. Also, when you have to position the clips, is important because you avoid the risk to put the clips near the main biliary tree, and you can check the position of the clips. You can keep in green. If you have a button of the camera, you can switch to a normal view, to ICG view, but you can leave in ICG view all the time because you are in color. For this reason, we have no problem, and you can perform the section of a cystic duct. And is also useful when you have to remove the gallbladder to follow a plane of dissection between liver and gallbladder. Then we can move to urology. There is a lot of urology application. As you know, in pediatric surgery is a general surgery because we operate children in thorax, in the abdomen, urology, gynecology. For this reason, we can try ICG technology in several different applications. As for the urology, for example, the first application that we have adopted is the ICG fluorescent lymphography in patients operate for varicocele. As you know, why to perform this technique for patients operate for varicocele? Because the technique that we adopt in laparoscopy to correct varicocele is the Palomo procedure. It means that we have isolate all spermatic bundle, we have to clip and then section it. But near the spermatic bundle, there are the small lymphatic vessels. And the smallest lymphatic vessels are difficult to identify because under your eyes, they are similar to normal vein. If you inject in the testis ICG solution, these lymphatic vessels became greens or blue, and you can identify and spare them. If you section all the lymphatics, the patients will have in 30–40% of cases a postoperative hydrocele or lymphocele, and sometimes he needs a new operation. Using ICG, you can identify the lymphatics, you can spare them, and in this way you can avoid the postoperative hydrocele. As for the injection, you have to perform intraoperatively. The cholecystectomy is the only indication in which you have to perform the injection the day before surgery. All the others indication you have to perform the injection intraoperatively. You have to dilute the vial with 8 milliliter of distilled water, and you have to inject 2 ml directly into the testis. And as you know, the ICG technology and Storz Rubina system have several modality of color. You can see in green, in blue, or in white. However, I will show you. This is the spermatic. This is the old system. You can see we switched to ICG view, and lymphatics became green. In general, there are 2–3 lymphatics, and you have to spare them. You can see it easy to identify them is real time, because after the injection, after 30–60 seconds, you can identify the lymphatics, and you can spare them. You can keep the spermatic bundle, and you can put far away from it the lymphatics. Switching from the normal view to ICG view, you can see the lymphatic in green, but with fluorescence technology is better to see in ICG view. For this reason, you can identify, you can spare the lymphatics, and then you can section and clips all the bundle. Lymphatics in this way are spared. And this is the Rubina mold, the same pathology, the spermatic vessels, and we inject the ICG in the testis, and you can see the lymphatic became green. As I told you, there are 2 to 4 lymphatics, and you have to spare them. If you don't use ICG technology, it's impossible to identify the lymphatics. This is the view in green, but as I told you, you have different kind of view. You have you can switch to the blue mode, and lymphatics appear blue, or they can appear also in white. And using this technology, we have 0% of hydrocele postoperatively. We have operated hundreds of patients using this technology. And if you don't use this technology, in 30–40%, you have a postoperative hydrocele. Another indication, very interesting indication, is the patients with a double kidney, in which you have to perform a partial nephrectomy. This is another pediatric pathology. There is a congenital malformation in which the kidney is formed from 2 different entities, 2 kidneys, one on the other, and one of these 2 kidneys doesn't work. For this reason, we have to remove the non-functioning moiety with all the ureter. The problem is that you have to differentiate the vascularization of the 2 moiety of the kidneys, and this way ICG is useful. And then the 2 ureters of the 2 moieties are attached to each other, as it's difficult to identify. For this reason, the ICG can be useful. I will show you different steps. Before starting this procedure, we perform a cystoscopy, and we position a catheter in the normal ureter. In this way, we can inject ICG during laparoscopy, and the normal ureter became green. And in this way, you can differentiate it from the other ureter. In general, the pathologic ureter that you have to remove is a mega ureter. For this reason, is very large, but is attached to the normal ureter. Thanks to this technology, you can identify the normal ureter, and you can avoid to damage it. Then you have the second step is to identify the vascularization, and you have to perform an intravenous injection after that you have opened the Gerota fascia, and you can inject and identify the vascularization. In this way, we can identify the vascularization of the moiety that you have to remove. You can clip and section them. And then at the end, you can test the normal vascularization of the remaining moiety. I will show you with the videos. As you can see, the first step, you have to differentiate the normal ureter. As you can see in the videos, on the upper part there is the pathologic mega ureter, and you can see in green the normal ureter. The 2 ureters are attached. For this reason, you have the risk to damage the normal ureter during the isolation. And thanks to ICG technology, you can identify, and this is for sure that you can see the Rubina mode, because you can see in the color. To perform this procedure, we use always a sealing device to perform dissection. In this way, the patient has no bleeding. And then the second step, when you have to identify the vascularization, this is the old system. We inject intravenously the ICG. This is, we have to perform a lower pole nephrectomy in this case. As you can see on the upper part of the main renal artery, and there are 2 arteries that goes to the lower pole. This is the standard view, and if you switch to ECG view, it's extremely clear. For this reason, you can isolate these 2 vessels and you can section them. And as I show you, you have to inject intraoperatively, and you need at least 36 seconds, 1 minute before identify the vascularization. And this is Rubina system. This is an upper pole partial nephrectomy. We inject the green, and you can see how the vascularization is more clear. You can see the main renal vein which a couple of veins that go to the upper part. This is an upper pole partial nephrectomy, and this is the Rubina view. As I told you, using Rubina view you can see in color. And then at the end, this is a lower pole partial nephrectomy. You can inject once again ICG intravenously, and you can see the difference between the upper pole that is normal vascularized, it appears in green, and the lower pole that is desvascularized, for this reason, is not colored in green. And this is way you can identify the lane of resection. To perform partial nephrectomy, you have to remove the non-functioning moiety and then hold the ureter, and you have to arrive near the bladder. And then at the end, as I told you, you can check you leave one moiety, and one of the risks of this procedure that you can damage the normal moiety, and you have to inject ICG for the third time, and you can check if the residual moiety is viable, and you have no problem with vascularization. For this reason, in the partial nephrectomy, this technology is useful at beginning to isolate the ureter, in a second part to isolate the vascularization, in the third time to check the devascularized zone to identify the line of resection, and then you have to check the vascularization of the normal moiety. This technology you can use also in robotic surgery. We have a robotic pediatric program, and as you see, this technology is included in the Da Vinci XI system. It's called Firefly, and this is a ICG-guided renal cyst deroofing. As you can see in the MRI on the left side, there is a huge renal cyst of the upper pole. Thanks to ICG injection, you can see the dome of the cyst that is not vascularized. For this reason, it's not colored in green. In this way, we can remove the cyst dome, we can remove the liquid from the cyst, and we perform a wedding. We put inside the cyst the perirenal fat to close the cyst to avoid recurrence. And ICG is useful because you can identify the dome of the cyst that is not colored. And as I told you, we published several studies. As I told you, this is as for urology indication, you can see partial nephrectomy, and we compare the partial nephrectomy performed with ICG technology with a normal partial nephrectomy, and thanks to ICG technology, we shorten the operative time and we have less complication. And then we can switch to oncology, because oncology is another application of ICG, and can be used in case of lymphoma or abdominal mass removal. For example, in case of abdominal mass, is useful to identify vascular anatomy, the ideal plan of resection, or for example, in thoracoscopy, and I will show you some videos. If you have a lymphoma, you can identify the nodes to remove. Or in case you have to perform an intestinal anastomosis, you can check the vascularization of the anastomosis. This is a robotic removal of ovarian tumors. So we use this technology to check if there are some node involved were negative. For this reason, you have ICG technology. To perform this procedure, we use a sealing device. We remove all the tumors, and then we put the tumor in a bag, and we remove through the umbilical orifice. It's important to use ICG technology to check if there are pathological nodes that you have to remove. And then, as I told you, in pediatric surgery, we perform also thoracic pathology, and sometimes we have to use ICG for some indication. For example, you can use it in case of thoracoscopic lobectomy for CPAM, congenital cystic adenoid malformation, and you can inject ICG to identify the resection margin, because you can see in the picture on the left the normal view, on the right part the ICG view, and you can see the cystic malformation is not colored and normal lung colored in blue. As I told you, you can use both blue or green color, you have to decide. Or in case of suspect of lymphomas, if you have to perform a node biopsy, you can inject the ICG inside the lung, and then you can switch. This is the classic mode with the pedal. You switch and you can check the lymphatic system, and if there are some huge lymph nodes to remove, as you do, we have in dangerous zone. For this reason, is important to have a good anatomic definition. You can define the node, the pathological node, that then we can remove in thoracoscopy. And then also in gynecology, as I told you, we perform also pediatric gynecology, and you can check one of the indication if there is a huge ovarian cyst or tumors. You can have adnexal torsion, and you can check the vascularization of the annexa. Also, if the annex it seems dark, you have to check the vascularization. In this way, you can perform a derotation. And as you can see in this picture, ICG is extremely useful to do that. And these are the old indication that we have tested. But as I told you, every year there are new indication. And as for the dosage, however, as I told you, we publish this paper in Frontiers for this reason. If you want, all this information are available on this paper and is open access. For this reason, you can download it. And there are all the dosage. And as you can see, or for the time of the administration, the only indication in which you have to administrate this ICG preoperatively is the cholecystectomy. All the others are perioperatively during the procedure. As the modality of the administration, in 2 cases you have to inject intraparenchymal, as for varicocele, in which you have to inject in the testis, and in case of thoracic pathology, in which you have to inject in the lung. In all the other indication, you have to inject intravenously. The advantages, probably the main advantage that we have with ICG in pediatric surgery are varicocele. If you have to perform a varicocele laparoscopic correction, ICG is essential. Or in partial nephrectomy, as I told you, to perform a partial nephrectomy, both to identify the ureter, the vascularization of the kidney, and then the resection is essential. And then also for cholecystectomy, I think we low to zero the complication related to dissection if you use ICG technology. And then for sure, also in case of lymphomas or tumors, is extremely useful, above all in thoracoscopy. Coming to the conclusions, I think that the main limitation is that you need special equipment, because you need a special camera, a special optic, for sure the vial, and before operating, you have to check if the patient is allergic to iodides, because it's contraindicated to use ICG, because you can have a cross reaction. The advantage, I think, using ICG, you can perform a safer surgery, and is extremely important in pediatric patients, above all in smaller children. And we report no allergy or adverse reaction. Is not time consuming, because as I show you, you can see the structure in real time. In conclusion, I think that this technology changed completely our find of operator in some procedures, as varicocele are as in cholecystectomy, in partial nephrectomy, in lymphoma, of if you have to remove tumors. You can use it in standard mini invasive surgery if you have source equipment, if you have a XI Da Vinci robot. The system is included, is the Firefly. For sure you need the vial, and for sure we are working on that, and I think further evidence with the larger series and longer follow-up is needed to confirm this preliminary result. I hope that after COVID pandemic you can visit Naples. Every year we organize a couple of symposium endorsed by Storz, and we have a lot of procedure in live surgery, and then there is a theoretical part. Next year we will have a couple of symposium on ICG in June and in November. Or if you want to try ICG fluorescent technology in animal lab, in dry lab, we organize some courses, one neonatal course on rabbit model, and one urology and robotic course on pig model in July and in October. And during these courses, you can try yourself the ICG technology in a dry lab. Thank you very much for your attention.
And thank you very much, Professor Esposito. 1 second. Okay, we're now going to begin answering the questions submitted during today's presentation. As a reminder for our attendees, you can still submit questions through the questions box on your control panel. So now it's the right moment to do that. If you have any questions for the professor, thank you very much. So Professor, the first question for you is, which are the main indications for ICG fluorescence in pediatric MIS surgery?
Allora, it depends. As I told you, probably the main indications is varicocele repair and cholecystectomy. In every pediatric surgery centers, I think we operate about 30-40 varicocele per year and at least 20-30 cholecystectomy, and this is the main indication. Then if you perform advanced laparoscopic surgery, you can use it for partial nephrectomy. Is a wonderful technique to adopt, or in case of tumors, in case of gynecological pathology, or if you perform thoracoscopy, you can use it for CPAM or for lymphomas. For routinary surgery, the best indications are varicocele and cholecystectomy.
Thank you, Professor. The next question, are there any age limitations to the use of ICG?
No. As I told you at the beginning of the use of ICG in clinical use, there were a lot of papers from adults. In pediatric surgery, at least in Italy, we operate patients from 0 to 18 years old, and we adopted ICG in any age with no limitation.
Thank you, Professor. Just a comment first, congratulations on your pioneer work. And the question, what reactions have you found in children with the administration of ICG by either mode, intravenous or intraparenchymal? Thank you.
As I told you, before using a product in clinical use, we check the literature. And the only contraindication that we found is that with ICG, you can have a cross reaction if the patient is allergic to iodine. For this reason, if the patients have as an allergy reported to iodine, you have to avoid using this technology. In our experience, we have no allergic reaction. However, our anesthetist always is ready in case of problem, but we have never had the problems. The only things that you have to check and you have to ask to the parents before surgery if kids is allergic to iodine or not.
Thank you, Professor. Next question. What is the difference between the old ICG system and the new Rubina system?
The difference is above all the different vision that you have. As I told you, the classic I will call ICG system. You have a pedal, and with pushing the pedal, you switch from the normal view to ICG view, and the screen became black gray without color, and you can see the structure colored in green. And switching again, you come back to the color. With the Rubina system, and as I told you, Rubina system, you can add Rubina component to your standard starts column. You remain in color. For this reason, you see the anatomic structures in green, but you can operate seeing in a normal color. And Rubina system offer also a 4K and LED vision, but for sure you need a screen 4K to see in this way.
Thank you, Professor. Please, can you explain which equipment we have to add to the standard laparoscopy equipment? Thank you.
First of all, you need the vial of ICG. As I show you in the videos, you have to inject a solution. You have to create a solution with distilled water, and as for the different indication, you can inject from 1 to 2 to 3 milliliters. And as I told you, in our papers published on Frontiers in open access, there are all the dosage and the way of administration. And I think that the timing to see the organs is in a real time, because you can see the organs in 30 seconds, 1 minute. As for the equipment, as I told you, you need the vial, then you need the optic, because the ICG optic, it has a special filter on it. You need the camera, a special camera, and the difference between the old system and Rubina system is that old system had a pedal that you have to switch, and you in Rubina you have to press a button on the camera to switch to ICG view to normal view.
Thank you, Professor. Next question. For biliary identification, what has been your experience when injecting within an hour before rather than the day before?
Yeah. At the beginning, we tried to use ICG intraoperatively. And if you inject and you want to identify gallbladder and biliary tree intraoperative, if you inject intraoperatively, first of all, you see the liver completely in green. And after a couple of minutes, you can see also the gallbladder and biliary tree. But it's difficult to identify them because the liver is completely green and you have not a good view. For this reason, we decided to perform the injection a couple of hours before, but you see still the liver. For this reason, we tried several times, and at the end, we found that injecting in 15-18 before is the best period. In this way, you have no liver identification, and you can see only gallbladder and biliary tree.
Thank you, Professor. The next question, what do you think of the use to hepatoblastoma?
I never had experience in this field because we use them at the moment only for renal tumors and for lymphomas, but I have no experience in hepatoblastoma using this ICG.
Thank you. Next question. Have you had any complications with the direct injection of ICG in the testicle? What caliber of needle do you use?
As before starting to use ICG to perform lymphatic sparing varicocelectomy, we use another product so-called isosulfan blue. This product was adopted in adult patients to identify inguinal nodes in patients with seminoma. And there was a huge adult literature in which there are showed that there is no complication and no lesion for testicular parenchyma after intratesticular injection. We adopted, first of all, to perform lymphatic sparing varicocelectomy isosulfan blue, but the problem is that you have a blue dot on the testis, and then the patients have the blue urine for a couple of days after surgery. And for this reason, we switched to ICG. And we have to publish this data. We studied the patients after the injection using ultrasonography and echo color Doppler study of the testis, and there is no lesion, no calcification of the testis in a short term and in a long term follow-up, with a follow-up more than 2 years after the injection.
Thank you very much. We have a question here. Why use such a small dose? It probably refers to one of your previous answers, Professor.
As for testicular injection, we use a 2 milliliter injection because we need to identify small lymphatics. And as I told you, you have to perform a solution with distilled water, and then you have to inject 2 ml in the testis. In general, we operate varicocele in patients after 15 years of age. For this reason, is like an adult testis. And the lymphatics will appear in 30 seconds, 1 minute, and then they remains green for about 10 minutes. But this procedure is easy to perform. For this reason, you have time to perform the lymphatic sparing procedure.
Thank you, Professor. Another question for you. What argument would you use to convince another pediatric surgery to start application of ICG, a pediatric surgery that is arguing they see the anatomy by the naked eye?
As I told you, I think the main advantage for cholecystectomy is the fact that, as I told you, we perform in pediatric surgery no more than 20, 30 cholecystectomy per year. Sometimes there is adhesions, sometimes the anatomy is not clear, above all in obese patients, because you have a lot of fatty tissue at the level of callo triangle. And for this reason, you have the risk to have a complication. If you have a serious complication of biliary tree, sometimes you have to reoperate the patients. Using ICG, you have a very, very clear view. And also a trainee can perform a cholecystectomy because you can see a real-time cholangiography and all biliary tree is in green. As for the other indication, the varicocele, as I told you, is extremely evident. If you see the video, you can identify the lymphatics and you can spare them. Today, I operated a patient with an hydrocele operated in another center with Palomo procedure without sparing spermatic vessels. He has a giant hydrocele with 200 milliliter of hydrocele. For this reason, is essential if you perform varicocele to perform a lymphatic sparing procedure. And for partial nephrectomy, as I told you, is fantastic because you can identify the ureter from the mega ureter, and you avoid to damage normal ureter, and also for kidney dissection and kidney vascularization. I think is mandatory in these three procedures to use ICG technology.
Thank you, Professor. The next question, at what age does the dosage of ICG change from pediatric to adult? And also, does the weight of the person play any role?
As I told you, we use the same dose in pediatric range. I don't know in which are the adult experience. And as for the different indication, as I told you, for example, you can perform several injections. In case of partial nephrectomy, for example, we perform 3 injections. The first one in the catheter to identify the ureter, the second one intravenously to identify the vascularization, and then the third one to identify the line of resection. For this reason, the change according to the pathology. As for adult experience, I have no experience with adults.
Thank you. Can we use ICG for pituitary tumor?
I am no experience in neurosurgery, and I don't know. I know that the oculus adopt for several pathology of the eye, but I no experience in these two fields.
Thank you. And the last question for you, Professor. Is there a special reason to dissolve 25 milligrams in 10 milliliters of water, hepatobiliary surgery? Normally 25 milligrams is dissolved in 5 milliliters.
I think before using this dosage, we speak with our anesthetist, and they propose them to lower a little bit the dilution, probably to reduce the risk of allergy reaction.
Thank you very much, Professor Esposito. Thank you for your presentation. That was our last question for today. Thank you very much for answering our participants' questions and the time you took to be with us today. Thank you, everyone, for attending today's webinar. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of International Society of Fluorescence-Guided Surgery, with grant funding from Diagnostic Green and our presenter, thank you for joining us today and enjoy the rest of your day.